Hello everyone, so I just checked. My queue from this ER is full of CT scans. Let's grab an exam and report from the clinical history all the way to the actual report. Let's go. I'm going to share my screen with you guys. This is a CT scan of the chest. This patient is a 84-year-old female. This is an unenhanced CT scan. It's downloading. We have around 1 minute to wait, so it's time for clinical history. Let's grab the clinical history. I'm downloading. It says patient has ascites, which is increased intra-abdominal fluid. It makes no sense for a chest CT scan. Also, it says she has an acute abdomen and hepatic liver nodules and mesenterial lesions, which have no apparent cause. This sounds like a very severe cancer patient with end-stage disease, so this might just be a chest CT scan for staging of a advanced neoplastic disease. Also, it says it has contrast enhancement. So let's load it. Here are the images. Indeed, there is contrast enhancement. Some sort of enhancement. No contrast enhancement. Here, contrast enhancement. The patient has one arm over her chest. This is a very poorly done exam of the worst kind, so it's contrast enhanced. Let's just type that in so we don't forget it. Let's see, we have an enlarged heart, we have diffuse calcifications of the aorta and the coronary vessels. Of course, the esophagus is distended and filled with liquid. Let's see if the walls are thickened. No, they aren't. The stomach and the intestines are distended, but this isn't a abdominal CT scan. Let's just focus on what we have at hand, which is a CT scan of the chest, which is by itself already a hard time for us. So let's go for soft tissue. There is diffuse edema of the superficial tissues and the muscle planes. This is a very sick patient. Bones, are there bone fractures, gross fractures and deformities? It seems the spine is quite deformed. I'm going to just hit an MPR button and make an analysis on the sagittal plane. So, sagittal. No, we are not going to look at the abdominal images. This isn't for me. I'm just here for the chest. So there is a partial collapse, a chronic fracture and a partial collapse of the 12 vertebral body and diffuse spondyloarthrosis of the dorsal spine, which is quite common at this age. So this is just an old patient being that old. So her hand is fine. She has done her nails. So we aren't going to speak of her nails on the report, as you guys are probably screaming on your seats because I haven't spoken of the massive pleural effusion on the right and the moderate pleural effusion on the left. I'm sorry, I'm just going through the protocol. You have to keep a protocol in order not to lose lesion, so ignore what isn't time to be looked at and look for what you should be looking according to your own protocol. I read from outside to inside, and there is some enlarged lymph nodes, not much on the axillary regions, and breast tissue seems as symmetrical as they could be, and is also all edema. So we have a large pleural effusion which seems homogeneous and free. Excuse me. And we have a moderate pleural effusion on the left, which also looks lenticular, so free, not loculated, not with signs of pleural thickening. We see here we have a major atelectasis of the lower lobes, especially on the right, also a partial atelectasis and anomalous filling of the airways of the middle lobe, also a partial atelectasis or collapse of the superior right lobe. We have some lenticular discoid atelectasis, segmental atelectasis on the left lower lobe, usually on the basal segments of such lobe. This is most probably related to the mass effect of such large effusions. Enlarged heart, atherosclerosis all over the place, but we can't really tell if there are proper secondary lesions on this parenchyma, this nodular thickening. I think this is just a intercostal lymph node. This is normal, so as much as these ones are also normal, so I'm not going to report it as a pulmonary nodule because it isn't. And this is it. Let's just report it. Just reporting the pleural effusions and the partial collapse of the right lobe. There is anomalous filling of the airways, so the middle lobe has this aspect, this feature, this morphology of a section of the liver parenchyma. This looks like a parenchymatous solid organ, but this is just a collapsed middle lobe. This is a hepatization of the pulmonary parenchyma. It looks like liver on the chest, so this means the airways are also filled up with anomalous content, usually mucus and inflammatory secretions. And there is partial collapse or atelectasis of a bunch of segments of the left inferior pulmonary lobe. Let's see, there is calcification of the aorta and the coronary vessels. The heart is very, very enlarged. What else? Are there lymph node enlargements? No lymph node enlargement, just a distended esophagus. Liquid distension with air fluid levels on the esophagus. And this is it. Let's just summarize this report to make it easier for reading by the referring physician. Let's see if we have a previous CT scan of the chest. No, I have a lot of CT scans from this patient, but no CT scan of the chest. So this is her first scan. Oh, I just forgot, we have a diffuse edema of superficial tissues, soft tissues. Usually severe cases of diffuse disease, systemic disease, present themselves with this kind of diffuse edema. So we are done. Let's sign it off. And of course, if you have enjoyed this video, I'm pretty sure you're gonna enjoy this next one right here. Just click here and keep watching. Thank you so much. Don't forget to hit that like button and subscribe to the channel. Share this video with someone you know enjoys diagnostic radiology. And until next time, I'll see you on the next video. So long.